Oh, it's awful.
It's a really
I mean, at least
fun
go over here.
I'm going to block with the people.
Right, okay. So,
No,
alright,
get
so,
a big screen.
so, no, it's fine, you can. So,
Sounds like you want to fix it.
when you first, no, you don't. So, when you first come into the room, you're going to be met with this screen. Yeah? Ah, God, I shouldn't have let you record me. I was just collecting cameras on me. So when you first come into the room, you're going to be met with this screen, and you're going to have the request card. Yeah? We're not going to trip you up with the request card. We're not going to give you anything that's like going to make you think really, really hard or anything like that. It's going to be a very, very simple request card. So give me some ideas of what you might see on the request card that's justifiable.
Confusion.
Say that again?
Confusion.
Not quite confusion. I wake up confused most
No,
mornings.
the
I need a
other
CT
patient in
scan.
CT is confused and according for the CT scan.
Confused, but what else? Yeah? For? Yeah? A bleed? Yeah?
Like
Which
any
is a
trauma
result
to
of
the head.
trauma. Yeah, that's it. So bleed, trauma, anything else?
Mass.
Mass? Yeah? Anything else? Stroke, yeah. So the main three things that we might be looking at. We're not going to give you anything more, I suppose, in detail than that. So it's going to be the main stuff, the main buzzwords. So as long as you've got them, you'll be fine in justifying the request. Beyond that, what else are you looking for on a request card? Referrer, anything else?
Patient details.
Patient details, exactly. Is it dated appropriately? Is it a referral from last year? Have you got a signature from the referring physician? Your patient details, are they all correct? Do they match up to what you need? All that kind of stuff, yeah? So once you've done that, you've gone through that process, the first thing I would advise that you do is come to this workstation, this acquisition desktop, click on patient registration, and input your details. You can just cancel out these. Anything that comes up like this, just cancel out of it. And then just stick in your name, it's going to be for the assessment. And once you put all your details, your patient details in there, over at the top, you've got a bunch of tabs for the different body parts. Over to the left-hand side, you've got a tab that says head. Click on that, and don't scroll down this one over here because the protocol that we're looking for is not over here. Go into head at the top over here, and then head helical standard. Just make sure that's highlighted, and you're good to go. All right, that's all set up now. But just before we leave this bit here, explain to the assessor that for this examination, the patient's going to be orientated to this protocol, head first, supine. Yeah, that's the way it's showing over there, and that's the way that we're going to set them up over there. We've got two scanograms coming out. We know that because there's two arrows here, one on top of the other, indicating there's two sequences there. And then you've got a scan. You've got the final scan even with one arrow indicating one scan, and the direction is going in. Okay, is that right?
Yeah.
Cool. So leave everything at this point over here. Don't click save, save and next, standby, none of that. Don't do any of that. This is all set up and ready for you to go now. So now we go in to the patient. You're gonna have to pick either one of two. You're gonna have to pick either one of two functions. There's this one here, and you've got the other one with the clear perspex over it, and it's just the skull at the back. You're gonna choose the yellow one. What's the first thing that you want to do when you enter the room?
Wash your hands.
Wash your hands. Anything else? Before that, say that again. Check doors are closed. You check the doors closed, yeah? Anything else? No? Check it's clean. Yeah. So make sure your room's clean. So you don't have to do these things. If you want to put your acting skills into practice, you can do this. It's direct to you. But just say to your assessor, at this point, I'm just going to make a visual assessment around the room, make sure it's nice and clean. We're not going to throw things on the floor for you to start moving. Just everything's going to be clean, but it's just so we know that you're coming in and you're taking into account these things. So cleaning, visual assessment, and then I'm going to wash my hands. So that we know you're doing the two things.
And you
Then
can
what
wash
do you
your
do?
hands.
Say that again.
I can do it now, or
Like you want me to?
no? Would it be now?
Yeah, now.
Yeah.
So you come into the room, clean room, wash your hands, and
Do we actually wash his hands or just stay?
just say, I
Oh,
wash my hands.
Okay.
Anything else? Sign it? Introduce yourself? Yeah. Introduce yourself and what else do you need to do in the introduction? ID check. Exactly. So we ID our patient, make sure that all matches up. So you don't have to actually do these things unless you want to talk to this guy over here. He's going to respond to you. But just say, I do my ID checks, all checked out, everything's good. Then what would you do?
Position.
Explain what you
Yeah, so you can.
Can you explain to the fan from the jump from
I mean, don't explain. You can have a
we
chat
jump
with it if you want. Yes,
as
say I've done my ID checks. At this point, I'd check with the patient. I'd confirm with the patient that this is the examination that we're going to be doing. Are they okay with it? If they're conscious of it. Yeah. Then what would we do? Position. Yeah. Take this, plonk it in here. So it's a bit difficult to see like this. So just twist it to yourself. And make sure it's nice and straight. Once it's nice and straight, you don't want to be moving that position side to side. You want to make sure that that thing is looking straight up. Okay? Yeah? You'll understand why in a second. Okay? So once that's nice and straight, back over here. What else do we want to do with the positioning of the head at this point?
Strap it down.
So not quite straps, but you would in a real life situation, I guess, if it were moving. In this situation.
Would you remove any kind of artifacts or
Yeah? Remove artifacts? Anything else?
tip up to get the, I forgot, EAMs
Yeah.
and the orbital baseline?
Yeah. So it's the infraorbital baseline. That's literally here. The infraorbital margin. And you want to draw an invisible line from there to the EAM. That line, that invisible line now needs to be perpendicular to patient. Yeah, like that. Okay. So we'll tilt the chin back a little bit. And start off, yeah, say what I'm doing. Because if I just started doing that, you're like, why is he tilting it back that much? How much is he tilting it back? Is he just tilting it back because he wants to? What's going on? Yeah.
Did you say why? So you say
Yeah. What's the why goal? What's the why goal?
is it to ensure that we're and that
So that's the baseline that we're following.
Because of this protocol,
Clinical departments will just do things as they do, and then they'll fix it on NPRs
So when you
afterwards.
say it's because of the control,
Yeah. So the protocol for this clinical site is to have an infraorbital baseline. You can have a supraorbital baseline. That would just mean tilting it down a little bit more. So the superior orbital margin in the EAM is perpendicular to the patient. Yeah. But for here, it's infraorbital. So we tilt it right back, and then put a little wedge there to keep the patient in place. Yeah? Is everyone okay with that so far? So now we know that we don't need to move this patient left or right, and we've got all of our head position perfectly for us to align the positioning lights. Okay? I'm just going to turn the lights on a little bit so you can see those lights. So, at this point, lights on. To be fair with you, you don't need to move with any of these at the minute. Use the foot pedals. So you're bringing the patient up and in to about this level, just in the initial stage, so you get them lined up with the lights. So we can see the sagittal positioning light here on the top. We can see the coronal positioning light on the side, just there. And we can see the axial positioning light just over here, running across. Yeah?
did you say each of my position?
Yeah, you have to say each positioning light for what they are. If you forget, this is the middle one, the one on the side, but it's better that you can say it with its actual terms. Coronal, sagittal, and axial. So, there's two axial ones, but I'll explain that afterwards. So let's start with the mid-sagittal one first. That needs to be aligned at the mid-sagittal plane. Okay? So, because we've straightened all of the head up now, we don't need to move it side to side. And when you're doing your assessment, you'll forget that. You can't move the entire thing. You shuffle the entire cushion about. And people do get flustered and they start moving the head about. When you start moving the head about, it changes the entire position. So move the cushion, okay? So for that positioning light, you want it to run through the mental of the mandible, so the tip of the mandible, Don't just say the mandible because the mandible goes from here down to here. Where on the mandible? So it's the mental of the mandible. And it's got to run over the mouth, through the tip of the nose, over the bridge or the glabella of the nose, and then straight up the top.
Right in the center.
Yeah,
So that's
right in the
mid-sagittal.
center. Yeah. So we know that you want to put that sagittal positioning light in the mid-sagittal plane. Well, where is the mid-sagittal plane? That's when you got to do the explaining. The mental of the mandible, over the tip of the nose, and over the glabella or the bridge of the nose. Yeah. Is that okay? Cool. So that one's all done now. We don't need to move that. In your assessment, if you feel like you can't see it properly from here, you can go to the other side and have a look, see if it's set there. You can go to the end. It's your space, it's your room, you do what you want. Okay? Don't feel flustered, don't get caught up in it. Forget the West up there, you just do what you need to do to focus. Yeah? Second one that we're going to position is the coronal position light. That's on the side over here. Yeah? Any idea where that needs to be positioned?
Yeah.
Yeah. So we're too far over here. It's too far to the anterior part of the face, isn't it? We need it to go back. So if we need it to go down, we need to bring the patient up. So bring the patient up nice and slowly to the EAM. Is that at the EAM now on the inside? Yeah? You happy with that? Then we've got one more light, the axial light. Just before I get to that, I'm going to show you where you can mess up with the coronal light. So before, do you know how we were getting the patient into the mid-sagittal plane? Yeah? If, however, I was over here and I panicked for a second and thought, oh, let me just put my head on that way a little bit. And that seems alright now. That EAM is now lower than this one. So if I'm stood on this side, my positioning is either going to be too high or too low. So if I position at the EAM now, it's there. Whereas on that side, it's going to be either
Too high,
isn't it?
yeah.
Because they're facing up.
Yeah, the tilt, so the EAM's tilt as well. Does that make sense?
Yeah. So you're looking to fix it then, right?
Yeah, you can still fix it if you come to this point. So at this point, if you do that again, whip this out, straighten it up again, back into the center, and then tilt it up again. Yeah? So just start again. You don't have to bring the entire thing out again. You leave it there because it's still in a good position, but just make your adjustments again. Is that alright? And then you can position your coronal light where it needs to be. And that's it. Axial lights, there's two of them. Does anyone know the difference between the two axial lights?
What's going to be in the tip and the top?
No.
Does it depend if you start caudally or cranially?
The last one is the main one.
Yeah. So this one on the inside, internal laser light, is the main one. This is where the radius, this is the business end of things. This is where the X-ray exposure is going to be happening. This one, the sole purpose for it is just to serve as a positioning aid. So if I'm stood over here, I'm trying to get into that middle one, I'm breathing on the patient, I'm breaking my back, it's just a whole lot of forcing. Whereas if I use this one, it's just right next to me over here, I can see what's going on, I don't need to reach into the scanner with my head and see where the light is. So you can do either one of two things. Because I'm all the way in there now, and I'm closer to that middle light, I can just position that there and be done with it, and just zero it. That's it, it's done. This position is ready. Zero. I'll explain in a second. So I can be done with it there. But if you wanted to use this one, all you have to do is position the axial light at the mental of the mandible, so just at the tip of the chin, over here, yeah, on the outside one, exactly the same as you do for the other one, but the only difference is for the outside one, you'd have to press P set. P set literally just means position set. So it transfers everything from this laser light to the one on the inside. It's just for ease of positioning, that's all. Okay? So if I press and keep hold of that, can you see how I've not done my full movement? Yeah? And it's kind of blanked everything out. Yeah? And the only buttons that are still active are that one, the reset and the P set. So you keep holding the P set. And you hear that really faint beat. and that's it. It's done.
Instead of doing anything with the bottleneck, can I just go straight?
You just go straight for the middle one.
Pushing the.
It's entirely up to you. It's entirely up to you. If you decide on the day you've got back problems, probably else going on the main, that one's there for you. Yeah? It's a gimmick on the scanner, so you might as well use it if you feel comfortable enough to. Or you could just go straight for that internal one. But don't let that confuse you. Okay? So now that I'm on the inside, I'm positioned appropriately, 0 it. This will go to 0. Yeah? Is that okay?
So if you're using the outside, do the P set. If you're using the inside, don't.
Yeah.
Okay.
Zero bot from that.
0, yeah, you're 0 and go. So once you've done that, laser lights off. What do you think you do at this point?
Right?
Yeah? You can ask the patient if they're alright. So yeah.
Make sure they assess when you say you're going to leave the room and make sure that everybody follows you.
Yeah, exactly. So, you tell the patient just before you leave though, tell the patient, say, or you explain to your assessor, say, I tell my patient at this point that I'm going to start the scan, I'll be leaving them, just keep nice and still. These are the key words, nice and still. I'll only be about 10 minutes. If anything happens, just give me a shout, I can leave through the scanner, but don't move. And I'll tell you when I'm about to start scanning, things like that. You know, just like conversation stuff. And then once you've done that, you can go. And as Alice needs to take us out with them, they come back and they start pissing about with it, and they mess it up. And in my head, I'm just like, oh, leave it, man, leave it. Like, everything was fine.
How would you get out?
You just need to come straight away. Yeah. So once you've done all this bit and you're ready to go through there, you say, can you please follow me through? That's your radiation protection part of your assessment. Okay? So make sure you're taking it smoothly here. Is that okay?
Yeah.
Cool. Yeah. All that so far? Yeah? So, when we get here, head helical standard, we're all set up like we were before. You've done all this talking, nothing's been changed, you set it up as it was, so you're good to go. You press start exam. Your patient is still good. Remember, intermittently, check in on your patient, make sure they're okay with you doing what you're doing. Alright? Again, this work report has come up, just cancel out of it. You don't need that. And patience is a virtue. Just in between steps, just take your time, make sure you've completed everything. Okay? So at this point, logic tells us we need to do a scanogram, doesn't it? Yeah? And that's exactly what the system's telling us to do as well. So there's nothing on here at the minute other than a continue button in this bar. You got to talk through this, all these parameters over here. So I'll talk you through them slowly so you understand them a little bit better. Number 1, so that's the number of sequences that we've got. It's the one that we're in. So remember we had 2 scanograms before, and we had 1 final scan, didn't we? So a total of 3. This is just number 1 out of them 3. That's all it is. Scan type S. Any ideas what S stands for? Scanogram, exactly. 2.5S. What do you think that stands for? That's it, exactly, the time. So this initial scanogram is going to take us 2.5 seconds to acquire.
You see second in there, or is it 2.5?
2.5S. Yeah. Tube voltage, 120 kV, set. If you click on that, you can't do anything. It's set for you, okay? You can't do anything with that. But just make mention of it. So this tube voltage, the kV is set at 120. Tube current, so the MA is set at 50. It's preset at 50. We're happy with that. Just say you're happy with it. So you have to go through all the levels, okay? But we don't alter it because it's already preset. The direction that we're scanning is out. We're coming out because we've positioned here at the mental and the mandible. So the patient's going to come out of the scanner. So we pass the rest of the head. Is that okay? The scanner length, 250 millimeters, 25 centimeters is a fail-safe one. Fail-safe, isn't it? It's fail-safe. Fail-safe. In case we forget to stop the scanogram. So it's not going to keep scanning up until the table's sort of length, the capacity, I suppose it's limit. And then scan mode, AP and a lateral. So we know we've got 2 scanograms like we've seen before on our previous screen where we had the 2 arrows, one on top of each other. Table index, 0, we've zeroed it, we know that, that's all correct. Auto voice, that's just the cues that the scanner will give you. Breathe in, hold still, breathe away, all that kind of stuff. It's off, that's good. We don't need any breathing instructions or any instructions from the scanner for these scan sequences. Don't worry about filters. Window, 350 over 150. So that, don't get that confused with the window width and window level for the actual final scan. This is for the 2D planar X-ray that we're gonna get the scanogram in the beginning, okay? So don't confuse that with the final window width and window level, all right? And then if you, that's it. All this is, the rest of it you don't really need to bother about. Collimation series comments, none of that. Just go up to window, and that's it.
What is the window thing?
Say that again?
What do you say about the window?
It's 350 over 150, and that's going to be to display our scanogram appropriately, so we can quickly adjust the field, not the field of view, but the start, the area of interest, the start of the scan, the area of interest, so on and so forth. Yeah, it's just so you're not faffing about with it. So all these things are preset, so they come up automatically. Okay, is everyone happy with that? So you're not looking at this bar confused now, are you? Because you know what's going on here. Yeah. So then you click confirm. This won't happen on the day, it's just because it's not been hair calibrated to this. So, like I said before, patience is a virtue. If you're sitting here for that couple of seconds, it can feel like a lifetime. Just wait for the scanner to do his thing. It's very obvious what it wants you to do at this point, isn't it? Yeah? What does it want you to do? Start. Did you remember before how I said, starting the scan? You want to explain it a little bit more than that. So, this is how you'd explain it. So, the scanner, the acquisition desktops prompted me to press the start button to start the scan. I know it's ready for me to start because the green light is starting flashing. So before I press that, check my patient, all good, still in the same position, I'd start it. So for this first one, I'm going to let it run its entire length. And you see how it's run over the head just by that extra little bit, like 10 centimeters maybe or something. So you can stop it just over the apex of the head, it's entirely up to you, or you can let it go. But it's good practice to stop it. I'll stop it for the next one, I'll tell you the little spiel that you'll need to say as well. So it's obvious what it needs you to do now, isn't it? Yeah, what does it need you to do? Move the table, exactly. So the scanner's prompted me to move the table back to the position, back to the starting position for the second scanogram now, yeah? And I know that because the move button is flashing white. Check my patience okay, press it, table's moving, going back into position, and we just wait for that second scanogram to load up again. So this is for the second scanogram now. Again, it's prompted me to start it, green button's flashing. This time when I start it, I'm going to hover over the stop button, and just as the scan passes the apex of the skull, I'm going to stop it. But before I do any of that, I'm going to check that my patient is still, and they're okay. They don't
Can
panic.
you do it fully?
Sorry?
Can you do it to go fully for this lateral one as well?
You can, but I'm just going to show you the better practice. So start, hover over the stop, check the patient, stop it at that point. Cool? Is everyone alright with that? So at this point, so I'm positioned way off kilter over here. So I've tilted the head too far back. But when you do actually do your like assessment and when you're positioning the patient, make sure they're positioned like perfectly because it'll help you at this point. Because you're not gonna, it'll help you when you've done your final scans and your MPRs will be a little bit more straighter, so you won't have to make as many adjustments. Okay? So this is really important. So can you see this purple line over here? Yeah? Yeah?
Yeah.
Ish? Yeah? It's right at the top of here. So if you drag that entire box down, just to the apex of the skull now, and then drag this line over, just so we're covering C1. It's difficult because, one second, see if I can, oh, there we go. So, I've got the purple line at the apex of the skull now. If I move this ever so slightly back, it stays. But if I move it a tiny bit more forward, if I advance it a little bit more, can you see how it jumped? Yeah? That jump is okay, but you don't want it to jump too far. That jump, all it's telling us is, can you see how it stopped over here now where I wanted it to? But if I advance it the tiniest bit more, it's going to jump a little bit more forward. For me to acquire that tiny little bit of information, the scanner has to complete a full rotation. So it's saying I have to acquire that additional information to get that tiny bit. So here, you might as well have it. That's what the scan is saying. People panic by that because they're like, oh, it's not staying, like, it's not doing what I want it to do, but that's okay. So, if you do need to move that tiny bit extra, it's okay if it jumps. It'll go to around about 37 or 41 images. It's going to 41 right now because if I bring it back up here, I'm just about clipping off the vertebrae that I need there. Remember, we need C1, okay? So if I was positioned a little bit more straighter, that vertebra would be a little bit more perpendicular to the sort of the length of the patient, yeah? So I'll move it over a little bit more, and then it's gonna jump down there. But if I wanted to bring it up here, can you see how it jumps straight down there? Don't let that panic you at all. As long as you've got the information on, you're all good. So in this case, I'm gonna move it over a little bit more, so we're including 41 images. But 37 images is round about what you want, okay? Just bear that in mind. This over here, if I cone this down now, can you see how it starts chopping the other side off? Because it's a tube and the center of the tube is over here. So just bring this nice and central and then open up just so you've got an equal amount of air gap on the anterior aspect of the skull, just as you do on the posterior aspect of the skull. Is that okay? Make sense? So we're all set up superiorly and inferiorly. Remember the orientations of it as well. Just because it's our left and right, this is superior of the patient and inferior of the patient. This is anterior and this is posterior, okay? And then ear to ear will be lateral, all right? So we can flick to our second image with this little arrow over here. If I start messing about with this, I'm just going to be messing about with the window. Can't really mess about with the lines over here. Click this arrow and it'll ping your AP over onto your screen. This is where the magic happens over here. So don't be confusing yourself by trying to fiddle with things over there. With this one, some students get really confused and flustered and they start doing this and then they panic right at the end because they've not noticed that it's closed the tube over here as well. So if you do that, make sure you're referencing the image next to it as well. See what's happening there. But if you do that, just flip that one back over and open up and adjust where you sort of.
So the AP one, you should just leave on top to bottom.
The AP one, the only thing I'd advise with the AP one is just centralize the box.
That's it.
That's it, yeah. Nothing more than that. You just want to make sure everything looks pretty on the other end as well. Okay?
Yeah.
So now that that's all set up, is everyone okay with that so far? Now that that's all set up, we'll start talking through our parameters bar. Initial thoughts, is it confusing? Does it look a bit much? Like, do you understand what's going on?
Everything's good, but explain the parameters and algorithm and all.
That's what I'm asking. So what's your initial feedback on that? What's your thoughts? Does it look too confusing? Does it, do
Everything,
you
the
understand
parameters
anything?
look confusing, but
Yeah.
this, everything else is alright.
So I'll get post feedback once I've explained it and then you can tell me how you see it. So bear in mind how you're seeing it now as well, because it'll tell you how much you've learned by the end of the session. So number 3,
Nice.
not quite, sequence 3.
Sequence
Yeah,
three.
so it's our third sequence. We know we're doing our final scan now. We also know that because under scan type it says V. V just means volume. That's just our final scan, okay? I don't want you to worry about the geometric efficiency, but that geometric efficiency is 83.3%. Forget about that, and then scan period is 13S. Yeah, so it just goes with, it just does the exact same thing. So the top title is the top sort of value there. The bottom title is the bottom value there, yeah? So scan period, 13 seconds. That's how long the entire scan is going to take. And then we've got the CTDI vol and we've got the DLP. Forget the CTDI vol, just go with the DLP. So our DLP value is 733.6, okay? At this point, you'd make an assessment of whether that's okay or whether there's something really wrong. Is it showing too low or is it showing too high? Do you think that's okay and that's acceptable for a head scan?
Is it because it's a high dose anyway as well?
Yeah, they're high dose scans anyway, yeah, but like you can get too high and then you can get too low with this as well. So what do you think?
The machine is preset to that anyway.
Is it?
I don't know. should
That
be.
happens based on the things that I've just done. So what do you think?
Okay.
Yeah? So that's within range. So you're looking for very obviously too low or very obviously too high. very obviously too low, being below the 500 mark. Like for an adult head, it's a little bit, looking a little bit low there. For an adult head on the high end, you're looking probably over perfect. Like this is, it's well and truly centered. Right? I'm in the ISA center there, so you're not looking over. I think when you start touching 850, you're probably looking at a bit high there. So make mention that that DLP is within the local and national DRL upper and higher limits, upper and lower limits. Yeah, DRL. Anyone know what DRL stands for? Gross reference levels. Yeah. Are you okay with that so far? If you need me to repeat anything at any point, please let me know. Start mode, the little hand, that's telling me that I need to manually trigger the start and the administration of that radiation. And I'm not just going to confirm and then it's just going to start automatically by itself. Yeah, because it can have automatic starts on it as well. We'll have to do that. This is just telling me it's another failsafe, so that I need to trigger the actual scan before it starts. You just need to explain that that's all that is. Don't worry about the contrast bit, non-contrast examination. Don't worry about the focus size, joint mode and series link. Again, forget about it, you don't need any of them. This bit you need, the MAS and the tube voltage. So the MAS and the kV. So let's go with the kV first, the tube voltage. 120 kV fixed. These are the things that you need to say. We're not going to be changing or altering that kV throughout the scan. 120 is fixed. S176 MAS. Anyone have any idea what that means? No? That's okay if you don't.
Current.
So, it is the current, but it's going to be modulating. So, does everyone know what modulating means?
Yeah.
Yeah. So it's going to change continuously throughout the scan based on the scanogram, the maths that is done in the background to calculate the different densities throughout that skull. Yeah. So at the apex of the skull, it's going to be a lot less dense than it is at the base of the skull because there's more bone, there's more thickness there. So can you see over here at the base of the skull how it peaks over here? It's really high, isn't it? Yeah. Whereas at the apex of the skull, it's really low, isn't it? Yeah. This being really low and then this being really high. Is that okay? So for the MAS, you just need to say that the MAS will be modulating throughout the scan, and I know that because this orange graph is doing its thing basically. Yeah, it's going up and down. It's pretty. It's moving. Yeah, there are different levels. That's the MAS and the kV explained.
So we don't get to say that it's moving.
I mean, don't say it's moving. Just
Modulating.
Say it's modulating.
Oh, yeah, yeah.
You've got good variety in your graph there, basically, is what I'm trying to say. Your number of scans, 13, and so with this bit, just make mention that you're not over scanning the patient. So you've got 13 scans, yeah, and you've got 41 images. You know that's within range of what you're trying to do here, okay? And the FOV, it says S209. Anyone have any idea what that is?
Field of view.
Yeah, so the field of view. So the field of view over here, if I open this up a little bit, it's going to change that value to S227. So this is based, that number there, that value is based on how much I open and close that. The S just means that it's small. Does anyone know the differences in field of views and why we use different field of views? Would we use the same field of view for a head that we would for an abdomen? No, why?
Bigger area.
Yeah, bigger area. So the circumference of a head is very different from the circumference of your abdomen and your chest, isn't it? So we use larger or medium field of views for them areas, and we use smaller ones for the head. This perforated line up here, right at the top, and this perforated line at the bottom, on the lateral scanogram, is going to show you the limits of that field of view. So if I reach that point, can you see how they've turned yellow? If I let go, they've disappeared altogether now from there, because I'm not scanning in that field of view. Kind of free-balling at that point. So if I bring it back in, I'm in the confines of that field of view now. So it's going to scan optimally from there. Okay? Is that right? So small field of view is basically what I'm getting at. So once you've come to that point, remember, reference back to your image and say these perforated lines are the limits of my field of view for this head scan. Okay? The thickness, don't worry about the collimation. The thickness is of your slice is going to be 5. Just make mention of that. That's all you got to say. And then the table direction is going in You don't need to mention the table index. You don't need to mention any of this. You don't need to mention any of the scan position. Not that, not that. And then we come to the delay. The delay is 2 seconds. Any idea what the 2-second delay is for? No? So as soon as I press that start button to start this scan, there's going to be a 2-second delay before the scanner actually starts scanning. That's all it's telling me. So I'll press the button and I'm thinking, crap, why is it not doing anything? So it's just telling me, okay? And then the series comments, non-con head. That's all you gotta know. You can change them, but don't just leave them as they are because it's a non-con head. Is that right? Everyone understand that? Is everyone, have your eyes orientated to what's on that screen now a little bit better than what it was before I started explaining? Yeah? Cool. At this point, click confirm. Just check your patient's okay. Make sure they're still in the same position. Everything's good. What's it telling me to do?
Move the table.
Move the table. It's giving me the prompt on the screen, and I know it's ready for me to move because the white flashing lights started blinking. Move that. Check my patient. They're still good. And then the system's telling me that it's ready to start scanning. I know that because the green light is flashing now. So if I press that, it's going to start scanning after that 2-second delay. And I know that because of this little bar over here as well. There's that 2-second delay in yellow, and in the orange bar is going to be the 12 seconds it takes to scan the rest of that. Okay? So just check my patient one last time, make sure they're okay, not panicking. If they are getting flustered, just explain to your SSA. If they do get flustered at this point, you just explain to them, stay still, final exam, and that's it. Keep an eye on them, press the start. 2-second delay that was, and then hover over the stop button. Watch your patient and simultaneously watch your screen as well. Just keep flicking backwards and forward. Don't press the stop button, just hovering over it for good practice in case something happens. So the reason you're flicking backwards and forward is to make sure that your patient's still okay and that you're still getting the images that you set up to get. Because you could be watching your patient, but your images could be coming out absolutely rubbish, and then you're having to repeat that, but you still gave that entire radiation dose and you didn't notice because you weren't flicking your eyes between both. Is that okay? At this point, go right over to the right hand side using the scroller, the little rolly thing here, the wheel, and just scroll from top to bottom and make sure we've got everything on. So go right the way to the top, we've got the apex of the skull on here, I know that, all the way to the bottom, and we've got well past C1 on there. So I'm happy with that. That's not the only thing we need to be watching for though. So we've done superiorly and inferiorly, we need to be doing anterior and posterior. So the most protruding part at the front of our face is our nose, isn't it? So we know that we've got the nose on over there, we've got the bone, we've not cut anything off there, yeah? At the front, yeah? And then at the back, we're all good as well. We're not hiding anything, we're not cutting anything off, we haven't collimated anything off virtually. Side to side now, laterally. Ears. Ears are a good reference, so your soft tissue. We know we've got the ears on, both ears, so we know we've got everything on in between that as well. Is that okay? Yeah? So over here, you're going to be very tempted to press continue, as some people have done, and they failed when they've scanned it again. But if you do, I'll show you how to get out of it. But you want to press exit. If you press exit, you're going to come to this bit over here. Do you want to exit from the current patient examination? You press yes, and it'll take you to another page, which I'll show you in a second. But say for instance, you press continue, and at this point you know you've done your scan, you don't want to do another scan, and if this is prompting you to do another scan now, you know you don't want to do a scan, you press exit, yeah? You know you've come too far. You're not going to fail, but as long as you pick up on the fact that you do not need to scan again. If you scan again, that's when you fail, because you overexpose the patient more than they need you to be. Anyway, so you exit, press yes, get rid of this box again, just a work report, and then you'll be brought to this page. Okay? So what we want from here is our thin soft tissue brain. If we click that, drag it over, we'll get our images, and we can see that they're loading over here on the side of this bar that's just running. You can scroll with the roller, the wheel, or you can scroll over here on the side, there's a little tab. Just make sure that you've got top to bottom, side to side, and anteriorly and posteriorly, everything that you need on. And this is the image that we're going to be using for our MPRs. Okay? So we've got everything on. Now what I want to do is go on MPR it. So we click on menu at the top. We scroll over to analyze. Click analyze. Drop down menu is going to give you right the way towards the bottom, real-time MPR. Click on that. Okay? And then we get the system brings up our 3 images in the 3 different planes. The first thing you want to do here, don't start messing about with this at this point. The first thing you want to do before you start altering things is go to triple. You'll see another image pop up over here with no line on it. Yeah? Over here, what you want to do is, the first thing I would do is find your hard palette. The best way to find your hard palette is going to be on this sagittal image. But to find our sagittal, to find out the perfect slice on the sagittal, we'll refer to the coronal. And can you see how the hard palette is not, you can't amazingly see it. Yeah? If we move this just off center, and you see how you get it into better view. Yeah? So if I move this one back into the center on the coronal image, it's gone. You can still see it, I guess. But if you move it off center ever so slightly, not too much because you lose it again.
She's gonna follow the seat.